All right, all yours, Holly.
Okay, thank you. Good afternoon, everyone, and happy World Oceans Day. For those of you who have some time a little later today, you might want to go to UN TV and watch some of the really excellent programming on today for World Ocean Day. I'm Dr. Holly Shaw and chair of the NGO Committee on Mental Health. I represent the International Council of Nurses here within civil society at the UN. And we have a wonderful program planned today, convened by Dr. Felix Torres, who is our inaugural chair of LGBTQIA plus programming. This is our third year of a dedicated program, and we're really very excited about it. I want to thank him for organizing this. I want to make sure to thank also Dr. Elaine Congress, the vice chair of this committee. It's really picked up a lot of slack over the last year, and all of the members of the executive committee. We're going to be working hard this summer to restore our previous robust activity in person, perhaps, but probably virtually, so that many people from around the world will be able to join us monthly and perhaps more often than that for programming around the critical issues of mental health across the lifestyle, from the life cycle, from children all the way up to older adults and elderly. And I'd now like to pass the microphone over to Dr. Torres, who's going to introduce and convene our exciting and important program today. Dr. Torres.
Thank you. Thank you very much, Holly. Good morning, afternoon, evening, wherever you might be right now. We are once again graced with worldwide audience, small audience, but we have attendees from Asia, Europe, North America, and South America. As Holly mentioned, I'm Felix Torres. I'm a clinical forensic and administrative psychiatrist, and my pronouns are he, him, his. I am the chief of forensic medicine for the state of Texas state hospital system under Texas Health and Human Services. I represent the American Psychiatric Association on this body. I'm also a special advisor to the APA and the UN and the corresponding secretary for the NGO CMH. I am also a very proud gay man in an 18-year relationship with my husband, and we just celebrated our Gemini twin third birthday. Every time that we have one of these, I always mention that because their birthday is on June 1st, and this is soon thereafter. I am honored to have convened such an outstanding panel for our third annual NGO CMH program, fully dedicated to LGBTQIA plus mental health. As we know, during the month of June, throughout the US and the world, we commemorate the pride of our community of lesbian, gay, bisexual, transgender, queer, questioning, intersex, and asexual plus individuals. We see the colorful rainbow flags. I was just at Pride here in San Juan on Sunday. We join members of our community, family members, allies to celebrate our identities, highlight the history and struggles of the LGBTQIA plus community, seeking to promote acceptance and equality and creating awareness about the problems that affect us. However, not everything is joy and parties, and beyond the events of the parades, there still exists great inequality, discrimination, homophobia, transphobia, and other unfavorable situations that negatively impact the mental health of the LGBTQIA plus community. The title of our program today is Social Determinants of LGBTQIA plus Mental Health, and it is aimed to highlight the struggles that lesbian, gay, bisexual, transgender, queer, questioning, intersex, and asexual plus individuals face throughout the world, and our need as mental health experts, providers, families, and allies to be more understanding, more inclusive, more caring, whether in our treatment or in our day-to-day lives and interactions. The social determinants of health are defined by the World Health Organization as conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And as we all know, mental health is health, and there is no health without mental health. So I certainly hope that today's program will contribute to the continued conversation of diversity, equity, inclusion, and belonging for the LGBTQIA plus community. And that brings me to introduce our first panelist today. It is my distinct—
Dr. Torres, I'm sorry to interrupt you. Can I just say one thing, and that is that we have some presenters who were not on the flyer, and I just wanted to make sure that our audience knows we're going to produce another flyer afterwards for their records, but we're very pleased to be joined by Mama Dragons, who have visited us before and have very important information to share with us. So I just wanted to make that clear that they will be speaking at the end of the program.
Yes, no, definitely. They are with us, and I got all of their info. So our first panelist, it's my distinct honor to introduce, is Dr. Eric Rafla-Yuan. Dr. Rafla-Yuan is a San Diego psychiatrist and a voluntary assistant clinical professor at UC San Diego, where he founded and led the Psychiatry Residency Diversity Committee. He graduated medical school and completed additional training in bioethics at the Vanderbilt University School of Medicine and completed residency training at the UC San Diego Community Psychiatry Program. He's appointed to California State 988 Technical Advisory Board, previously served as Senior Policy Advisor for the San Diego County Board of Supervisors, and has held a number of leadership positions with local and state organizations, including the San Diego County Medical Society, the San Diego Psychiatric Society, and the California Medical Association. His research focuses on policy and structural drivers of health outcomes, and his work on 988 and clinical crisis services has been published in popular media, as well as the New England Journal of Medicine and Health Affairs. He is recognized nationally for his work, serving as the chair of the American Psychiatric Association Caucus on Social Determinants of Mental Health, a delegate in the American Medical Association's House of Delegates, and vice president of the Association of LGBTQ+ Psychiatrists. Dr. Rafla-Yuan formerly served in Washington, D.C. as Health Counsel and staff director of the bipartisan 988 and Crisis Services Task Force in the United States House of Representatives during the 117th session of Congress. The title of his presentation today is The Political Determinants of LGBTQ+ Mental Health. And let me quickly share the brief abstract. The social determinants of health are the conditions in the environments where people are born, live, learn, work, play, worship, and age, and affect a wide range of health, functioning, and quality of life outcomes. This talk surveys recent policy decisions in the United States which have influenced these social determinants towards worsening mental health outcomes for LGBTQ+ individuals, and provides a framework for systems-level strategies to reverse this trend. It is my pleasure to turn it over to Dr. Eric Rafla-Yuan.
Thank you, Felix. For that introduction, I'm going to go ahead and share my slides now. Is this coming up okay? Okay, we'll go ahead and get started. So as Felix mentioned, my name is Eric Rafla-Yuan. I'm a psychiatrist. I'm physically here in San Diego, but have lived both in the United States and China. And so I have no financial disclosures for this, but did want to make you all aware of some of the past experiences and positions I've had, which influenced my perspective. Felix went through a number of them. I speak only for myself today, not on behalf of any of these organizations or government roles. And so looking at the agenda, we'll do a brief introduction to the social determinants of health. I'll try and keep that brief because I'm sure most of you are well aware of these by now. We'll also then talk about a framework which may be a little bit newer for folks, the political determinants of health. Look at how that has affected health historically, as well as here in the present day in the past few years. We'll walk through some case studies about how these political determinants of health have specifically affected LGBTQ+ individuals, families, and communities. And then we'll also briefly talk about how clinicians and advocates can get involved acting on the political determinants of health. And then hopefully we'll have time for questions either at the end of this or at the end of the full session. So going through the social determinants of health, we've already heard the definition twice. And so this is just a brief review of what the CDC defines, and that is very much in line with what the World Health Organization defines the social determinants of health. And what I'll say the most on this is it's now been really nice to see the uptake of this, both in the United States and internationally, of the recognizing the importance of this, And with that importance, the need for further research and for further funding. But one thing that I think that where this framework lacks, or where it kind of fails, or it's not quite enough, is when we think about, well, we have these social determinants of health of, for example, economic stability, education access, healthcare access. But how do we as clinicians make a difference in that? And how do we do something beyond just saying, well, this person needs housing? And so there are some diagrams about this in sort of a more academic version. So this is from Ruth Shim's textbook on community psychiatry. Another diagram, which is basically a more visually appealing version of the same thing. I'm showing these. And so these diagrams give us some hints. So at the bottom, if you look at it, it says public policy and social norms. So it matches the same on both of these. But these gives us hints as to what drives these social determinants of health. And so when we think about what drives them and where do they come from, one of the things that I think is really important for us to understand is that social determinants of health don't just fall from the sky or grow out of the ground on their own. They really are driven by policy and political decisions. And when we talk about health disparities, and we do intensive amounts of research onto, what is health disparities, who experiences health disparities, and what are the effects of health disparities, and get down in the research world to a really granular level. Where we sometimes fail to look at is that health disparities are the expected and sometimes intended outcomes of these decisions. And so we'll use the United States here as a case study. I'm working both in the state and federal levels here in the United States government. This is just what I know the best, but I think that much of this kind of framework applies internationally. And so here in the United States, and as well as most of the world, health has always been political. And so we'll go through a couple of examples from the very founding of the United States. And so beginning in 1798, it was the United States' first experience with a nationalized health service. And so this was the Act for the Relief of Sick and Disabled Seamen. And so what was happening, this was when the United States was still primarily colonies on the Atlantic seaboard, and trade and travel between these colonies was the primary economic driver of the new country. And there was an issue where the sailors were getting sick and there were no health facilities, there were no places for these sailors to get medical care, and importantly, it was impacting the economic upturn. And so the colonies petitioned the new federal government for aid in providing health care to these sailors. And so this was, from the very beginning of this country, we had a nationalized health service. It was specifically for sailors and for people that worked in the ports. And this really has demonstrated that government chooses to intercede and exercise its power to promote the general welfare. So this phrase is actually in the United States Constitution, but importantly, depending on who is impacted. So if we move ahead about 100 years, we get to the Civil Rights Act of 1875. And so there's a lot of work now being done looking at health disparities and anti-racism and how these are connected. But if we look at historical policy, there's some very clear reasons why we have the health disparities in this country that we do today. And so there was a number of federal laws that were passed after the Civil War in the United States to try and reintegrate the South and the North, and to try, importantly, as a part of that, to try and reintegrate or to integrate newly freed slaves, Black individuals and their families, into the economic and social fabric of the United States. Unfortunately, in 1883, less than 2 decades after slavery was abolished, the Supreme Court of the United States struck down anti-discrimination provisions of the Civil Rights Act of 1875. And their reasoning in this was that 18 years had been enough time for African Americans to overcome the effects of slavery and get back home. And so, when I first read this, when I first learned this, this was sort of a shock. It's like, well, here is the obvious reason why we have health disparities. And it is where we should really focus our energy in looking at, well, why Black individuals and their families have worse outcomes, or perhaps more on what are the policies behind this and how can we change these policies. And so Adjacent to this, the Freedmen's Bureau was an actual federal level agency in the United States that was established to provide food, healthcare, shelter, apprenticeship, and legal aid to improve the health and independence of the newly freed. And so here was an actual agency with staff and congressional mandate and funding to do this important work. The unfortunate part is that it only existed for about 7 years. And for those 7 years, it only received federal funding for about 1.5 years. And so if we look at what we say is important and where we actually invest money in following up those promises, that has also historically not been there. The National Mental Health Act of 1946. So this was the first United States federal investment into the research for causes, prevention, and treatment of mental illness. So this federal legislation was quite large, quite revolutionary. At the time, this led to the creation of the National Institute on Mental Health, the NIMH, which some of you may be familiar with. It also led to the development of what has gone through a couple of name iterations, but now is known as SAMHSA, the Substance Abuse and Mental Health Services Administration. So here in the United States, these are very important agencies for us in terms of driving research and treatment and funding for mental health and substance use disorder treatment and prevention. The reason why this became federal law was that, so you may notice the date on this, 1946, there was also a world war at this time, World War II, and the US military released a report to Congress basically describing that there were too many otherwise men of the right age to enlist in the Army, in the Navy, and the Air Force who were disabled or not well enough to serve because of mental illness. And they described this as a threat to national security. And so that actually was the driver for what we now rely on for mental health treatment in the United States today. And so when we look at how these things came about, there was a lot of policy and behind that a lot of politics in making these things happen. And so when we model how this political determinants of health process works, we can look at it in 3 key parts, kind of undergirded by advocacy. And some folks, instead of advocacy, prefer the word education. And so that's okay too, perhaps depends on the role you have or the organization you're in. But in a functioning democracy, voters can directly influence policy, whether it's a ballot measure or by putting in place government officials. And so you see all of these things are interconnected, putting in place government officials who then pass laws that represent the voters' interest. There's also an interplay between government and policy. And so an example of this is if we think about, well, if we have a policy that's supportive of mental health that was put in place by a prior government official or a prior president, something like this, and then we have a new president, well, then the implementation of that policy can change. And so all of these pieces are important. And clinicians have a role to play through all of it through advocacy and education. So that's demonstrated at the bottom of the diagram. So moving from history to today. And so we'll go through some case examples of how this political process of health has been negatively impacting LGBTQ plus individuals. We'll also look at some examples of how it's been positively utilized. But unfortunately, as you probably know and are aware in the United States, and I'm not going to spend too much time on this because I am sure a number of the other presenters will go into more detail. But I'm just sighing as I pull up this slide. It seems like you can't go another week, another day even without another terrible headline from a city or a state somewhere in the United States about policy decisions that are worsening the health of LGBTQ plus individuals and especially kids. And so here, I'm here now in San Diego, California, and just next door to us in San Diego County is Orange County. Some of you may know that's where Disneyland is. It's a kind of a popular tourist destination. So just yesterday, the Orange County Board of Supervisors voted to ban display or demonstration of the pride flag on county property. And so here, even in California, these things are happening. And so here are just some examples of these headlines from the past few years. And the one on the right, demonstrates really that this political process is really in action, with hundreds of bills impacting LGBTQ plus individuals, and through that, their health. And a lot of them have really been focused on transgender people. And so these state policies are really linked to worse health outcomes. And so we'll go through an example here. But in February of last year, Texas Governor Greg Abbott issued a directive which got a lot of news publicity, basically that mandating law enforcement and social workers through I don't remember the exact name, maybe at some point Felix can help me out, but basically the child welfare system in Texas to investigate parents who provided this care, or physicians or clinicians who provided this care for transgender children. And so lawsuits were filed under this, but it continues to lead to numbers of families being investigated for providing gender affirming care for their children, as well as physicians leaving the state and family members and their young ones basically leaving as refugees to try and get the medical care that they need. And we're seeing this in parallel as well with reproductive health care. So a very specific example of this outlined in one of the lawsuits that was filed in the Texas state court system. So on the same day that Abbott issued that directive, a 16-year-old transgender boy unfortunately tried to kill himself. And he reported that the reasons for doing so were the political environment, including this directive, as well as ongoing issues at school, such as being misgendered, that led him to take these actions. Fortunately, he survived the attempt and was admitted to a psychiatric facility. And ostensibly that's a good thing. But for the staff there who were now under this legal mandate to report if gender affirming care was being provided, the staff learned that he was undergoing this care and reported this to the state agencies. And so a week after he was discharged, state investigators visited the family's home, and the family remains under investigation for child abuse. And so we can really see here how this political process has undermined the otherwise what we like to think of as ostensibly beneficial healthcare system, where people are able to get mental health care, where they're able to get gender affirming care, where they're able to get care for substance use disorders, and really becomes that the quote unquote care that they get through this leads to repercussions. And so when we concretely, what are political determinants of health? And so here's another diagram, and I think it's really important again that we remind ourselves that health disparities are the expected and unfortunately sometimes intended outcomes of policy decisions. And so when talking about outlawing gender affirming care, as was the case in Texas and a number of other states now in the United States, this is a intended political decision that unfortunately has really negative health outcomes for LGBTQ plus individuals and their families. And there are a number of other ones as well. And so we talked a little bit at the beginning of the talk about the effects of slavery and the failure to integrate individuals into the society. And so looking at all of these things here, none of these were things that we necessarily can do much about from inside of a hospital or a clinic room or a treatment setting, but have such huge effects on the health of the people that we work with. And so we'll shift to another example now here. This one was a little bit more positive example, some progress in the last few years. So jumping now down to the box outlined in red on the bottom right-hand corner about policing and criminalization. So policing has had a historic impact on LGBTQ plus individuals in the United States. And it has been an ongoing and pervasive problem. And through intersectionality, people of color, youth, and transgender individuals are particularly vulnerable to these effects, which have included profiling, entrapment, and at times violence. And so this is a case featured in the Washington Post, as well as other local papers in Missouri, that happened in 2019. So Stacy Kenny, whose parents are pictured here in the photo and whose picture herself is in the frame that we're holding. So she was a 33-year-old white trans woman who had been diagnosed with schizophrenia. who was pulled over by police for a routine traffic stop in Missouri, where she lived. It was at night and was sort of dark, and it was sort of like an odd situation, and so she called 911 because she wasn't sure if they were police or what the right thing to do in this situation was. While she was on the phone with a 911 operator, the police officers, and this happened in like a very quick amount of time. So this is not like there was like 5 or 10 minutes. This happened very quickly. Police officers smashed the windows of the car, tasered her, pulled her out, and eventually just shot her. And so the family ended up getting a large settlement for this, but the reason most likely for this was that both the video and audio recordings became publicly available. In most cases, this is not the case for LGBTQ+ folks who suffer violence at the hands of law enforcement. And so this was something that I felt very strongly about that should change. And so I've worked on this in a number of arenas. And so one is sort of in like the research and scholarly arena. And so this was an article I'd written on this in the New England Journal of Medicine. And really what me and my co-authors described in this article was the need to develop a crisis system for psychiatric emergencies for individuals with mental health and substance use disorder related emergencies, that in this system that they were able to get the same level of care, be treated with the same level of dignity and respect as if they had any other kind of medical emergency. And so what this looks like is a continuum of care, where you have a person who, if they are having a crisis, and reach out to a crisis line. So now in the United States, that's 988. We'll talk a little bit about that. And so similarly to how if you have a medical emergency, you could reach out to 911. How if they were not able to resolve it on the phone, that it specifically trained professionals with the right equipment would be dispatched out to respond, just like you have an ambulance with EMTs and paramedics with the right equipment and supplies on an ambulance to respond to these types of medical emergencies. And that if you needed more assistance than could be provided in the field, that there was a designated place where you could be taken to that was not an emergency room, that was certainly not a jail, but was rather somewhere that was specifically designed for mental health crises. Ideally, it's a quiet, supportive, home-like environment that, importantly, unlike emergency rooms, is really attached to longitudinal wraparound care to make sure that the person in crisis doesn't continue to have this, doesn't get discharged right back out into the same situation that induced the crisis. And so so this has been rolling out in various pilot programs here in the United States. And so here are a couple of examples of this. This is a program called STAR in Denver, Colorado, using this community response approach to mental health and substance use disorders. And they found a number of outcomes. So one, it quote unquote reduced crimes. A large part of this is because one thing that happens when police respond is that they tend to one of the ways that police know how to respond to things is to file charges. So whether that's writing a ticket, whether that is various things because they find something on the scene, or there was someone else there that they found that was doing something, or let's say someone was having, was suffering from an overdose, and they find drug paraphernalia at the scene, and so these kinds of things add up. And so by having non-law enforcement individuals respond, not only did people feel safer reaching out for help, but that the individuals who were reaching out for help in times of crisis were less likely to be charged with crimes and therefore more likely to get the help that they needed. It also found that police backup was in the period for this study was about 6 months. Police assistance was never needed. In studies from other jurisdictions in the United States, the number ranges between 2% and 7%, depending on the jurisdiction which police backup is called, but really demonstrates the point that police are really not, armed law enforcement are really not necessarily the right individuals to respond to these. And when we have the specifically trained individuals, police backup is only needed in a very small minority of cases. And in addition to improved outcomes, I also found that it was reduced cost because individuals were less likely to reutilize services. They were more likely to get connected to the services they need the first time. And law enforcement response is actually very expensive on its own. And so taking this nationally, so one of the things that I did while I was in the House of Representatives was served as the staff director for the bipartisan 988 and Crisis Services Congressional Task Force. So this was an effort federally to implement 988 and a crisis continuum of care across the country. And so this was led by Congressman Tony Cardenas, a Los Angeles congressman who I worked closely with, and his picture is up there on the left. Got a fair amount of media attention. So I talked with the New York Times, Washington Post, NBC, et cetera. Some of this is featured here. We wrote a significant piece of legislation, large portions of which ended up being signed by President Biden at the end of last year. And so a very important date in all of this in the United States was July 16th of 2022. And so this was the day that 988 went live across all 50 states, all tribal areas, and all of the and 5 American territories abroad. And so what is 988 here in the US? And so 988 is a easy to remember, easy to access 3-digit number that you can reach by a number of means. So in the United States and the territories and tribal areas, you can call to 988 from any landline or cell phone. You can text directly to 988. You can also access 988 online at 988lifeline.org or 988.gov. It routes to the same place. And when you reach out to 988, you are connected to a trained crisis counselor that sits at one of the more than 250 crisis centers now located geographically across the United States. Some of the territories also have one. So for example, Puerto Rico has one crisis center there locally. So 988 is also free of charge. And so when someone reaches out to 988, 988 never has a charge. A small caveat to this is that if someone is on a phone plan that charges per text or per minute, 988 is not exempt from that, but the 988 service never has a fee. And what can folks reach out to 988 for? And so an important piece of this was expanding what 988 was able to respond to. So historically, there were a number of hotlines, including the National Suicide Prevention Lifeline, the Veterans Crisis Line. There were large number of local hotline numbers. Basically every city, every county had various versions of these kinds of things with all of them different numbers. And so an important piece of this was all getting wrapped into 988 so that no matter where you were, you could reach out without having to figure out what this number was. But also expanding what it's able to respond to. So someone can call 988 for any kind of emotional distress. And so that could be thoughts of suicide, but also any kind of mental health crisis, substance use related crisis. Someone can also call 988 or reach out through text if they're worried about a friend or a family member or someone else. The call doesn't have to be about themselves. And when they call 988, so they're guaranteed to be connected to that trained crisis counselor. And then depending on the area that they're in, the rest of that continuum of care is continuing to be implemented. So this is where there's more need for state and local leadership on this. And so in some places, so here in San Diego, for example, they are able to connect you to a mobile crisis team. And so the linkage is a place where work continues to be done. And we hope to see progress over the coming years. So 988 incorporated the Veterans Crisis Line, the National Suicide Prevention Lifeline number. So Canada is also launching a national 988 hotline and incorporating their own numbers that is set to launch in the fall of this year. The UK and New Zealand are looking at similar things, but using a different number. They don't use they have a different 3-digit code for emergencies there. And so, but looking at the same idea. And so why specifically is this important for LGBTQ plus mental health? And so we talked a little bit about why it's important for individuals to be able to reach out and feel safe reaching out and not be worried that police are going to be the ones to respond or that 988 is the only resource for this. But something specifically that was done was that 988 now has specialized services for LGBTQ plus folks. And so so here's a press release from the Trevor Project looking at that. So some of the initial legislation that was done just tasked federal agencies to look at a strategy for implementing this. And so what I led when I was in DC was the actual requirements to do so, as well as the funding to be able to do this. And so that successfully launched. And so very excited to say, so now through the 988 Lifeline in the United States, individuals reaching out have the option to get connected to a specific LGBTQ+ trained crisis counselor, who the majority of the times is LGBTQ+ themselves. This service really was kind of designated with LGBTQ+ youth in mind, because we know that they are at extraordinarily high risk for poor mental health outcomes, including suicide, because of the increasing amounts of discrimination and stigma that them and their families are enduring. But so this, I think, is a positive example of how, and so here is an article about this, specifically looking at, despite the things worsening in some ways, it's improving in other ways. And so unfortunately, this is not like a balanced scale, but it does demonstrate the work that advocates and clinicians can do, and where continued work needs to be done, and how this progress, or this political process of health, can be utilized both to improve health outcomes as well as to worsen health outcomes. And so looking at how can we all be involved in this process, and so going back to this diagram, and so voting, and so I vote. I encourage my patients to vote. There's actually good evidence base, and the AMA just declared last year that voting is a social determinant of health. And this was based on research showing that people who vote have improved health outcomes. And so there are a number of pieces for this. And so one is that voting demonstrates representation, and in a representative democracy, people who are in government are in the business of getting elected by voters and by responding to the needs of those voters. And so communities that vote, by and large, get more resources, and through these resources get better access to healthcare. There is also things like, for example, in California now there are ballot measures about protecting reproductive health access. And so although that is current state law, to enshrine that in the California state constitution. And so these are ways that voters as well directly can protect their access to healthcare. And so government, some of us, here on this call at previous times or currently have seats in government, whether that's, state government, local government, federal government. And so we can be directly involved in designing and administering these policies. There's also the work of the implementing policies, and often this policy touches on many sort of organizations outside of the government, whether those are research bodies or things like this. And so there are ways to get involved there. And then all of these pieces can be influenced, both the public as well as the government and the policy, through advocacy and education. And so really specifically, I just want to leave you all with some closing thoughts of how us in the organizations that we live and work in, and specifically what we can do to protect LGBTQ+ health. And so one is kind of I broke it down into external and internal. And so one kind of externally, so making sure that our organization has a clear stand on these issues. And so an example here was the staff member in the hospital in Texas who ended up reporting that individual. Is that something that would happen in your organization? Is that something that you have a clear organizational policy on? Is that something that the people in your community know because you have this stated this kind of clearly in an external way? And another thing is education and outreach. And so educating the public, educating the lawmakers, a lot of work needs to be done here. Thinking about how we word things and how things are communicated to the public to help them understand that this really is about health and healthcare. And there's a number of position statements that some folks find helpful in helping defend what their organizations set as policies. And so I'll link to that there. So internally, making sure that those policies and procedures are in place to protect the health and privacy of patients and clients, and pre-planning for contingency situations. And so if a law does come down that it stops or prevents perhaps in your state, in your territory, in the country that you live in the city that you live in, makes it difficult or prevents you to provide the kind of care that you need? Do you have a contingency situation in place if this were to happen? Or if you predict that this might happen, then maybe even more important. And this is not just for your organization, but for the patients and clients that you serve and work with. So in conclusion, I hope you all are able to see that the majority of health outcomes are really driven by social factors, and themselves are driven by policy decisions, and that this is especially true for LGBTQ+ individuals, communities, and their families. This political process can be co-opted to improve or worsen health outcomes, and throughout history has often been used to worsen health outcomes, especially for LGBTQ+ folks. We looked at a number of case examples about how this process has played out, both historically as well as more recently, and talked a little bit about how clinicians and organizations have an important role to play in educating policymakers, protecting the health and privacy of patients and clients. So thank you all. Turn it back over to Felix. Happy to take questions now or later, depending on what works best for everybody.
Thank you very much, Eric. Yeah, I asked for questions on the chat. I didn't see any, but we'll take 2 questions from the audience now, and then we can leave other questions till the end. So anybody has a question? Yeah, Holly, go ahead.
Very much for that interesting presentation. I have 2 questions. One is I was shocked by the example you gave of the person in the hospital reporting the family. Isn't the HIPAA legislation federal, and wouldn't that be a tremendous violation of federal law, even though the individuals thought they were subscribing to state law?
Yeah, so this has been a ongoing issue. So like the kind of vagueness or the way implementation of federal versus state law, especially with a Democratic presidential administration and many Republican states. And I will also say that this kind of same exact type of situation has been playing out in parallel around access to reproductive health, specific abortions. And so one of the ways that states and state agencies and through these directives are justifying this is so many of the state and federal laws have a sort of blanket preemption in terms of that the privacy protections are abridged if there are concerns about abuse or about danger to the individual, things like this. And so many times the justification that they give is, well, this is child abuse, and therefore we are now mandated reporters to report this. And so that has been a way that they're doing that. And so the Biden administration has tried to tighten guidance around HIPAA for this, but it continues to be an ongoing issue.
Interesting. My other question is, I appreciated your concluding statements, but can you give us more information about allyship among organizations? I think most of us know personally how we can perform, as optimal allies, but how can our NGOs provide allyship to the community? Mm-hmm.
So unfortunately, where my expertise on this really is in the United States, I'm going to talk kind of specifically about that. And so thinking about kind of expanding from this social determinant of health model to a political determinant of health model, and thinking about the need for this kind of political action to protect health. And so that, opens us up to this whole larger arena of political actions. And so, there are organizations that are very active in this, but historically, this has not been necessarily like a top of their priority list. But organizations like the American Medical Association, which is one of the strongest voices in Washington, D.C. in terms of the amount of people and kind of, funding that they represent, historically was not necessarily an organization that was out in front in terms of reproductive health and gender affirming care and these kinds of things. And so one of the ways that I personally am getting involved is getting involved in these organizations to try and change the direction that they go in terms of what they prioritize. And so I'm now, one of the things mentioned before, so that the House of Delegates is the American Medical Association's policymaking body. And so I'm now a member of that body. and have introduced policies and supporting policies in that to try and move the AMA along in terms of this. I'm now the vice president for the Association of LGBTQ+ psychiatrists, and my initiative that will be starting soon is to really form coalitions with other organizations to really try and move advocacy for this along, specifically for physicians who a lot of times, feel strongly about this, but you don't necessarily know how to get involved or what to do about it. And so I see that a lot of people reach out to me and we're like, I feel really strongly about this, but I just see patients all day. I don't know what to do. And my patients are suffering, or I can no longer provide the care that I know is best for them. What do I do? And so to help sort of mobilize these folks or educate them in how they can get involved. And so that specifically is how I've gotten involved. There is a need for research, and so that's a way that other folks are involved. But for many of these things at this point, we have significant amounts of research, and it's not necessarily we need more research on it. We need this research to be turned into actual policy.
Mhm. Thank you.
All right, Elaine. You're muted.
Mute myself. Okay, yeah, thank you. I mean, what an interesting presentation. And I really thought it was so informative. And, as a social worker, and I'm involved with APHA, and also with New York Academy of Medicine. And then, of course, we talk all the time about social determinants of health, but you really made me think about how much policy and political decisions really affect this social determinants of health, which is really good. But it also made me think about, what about here, like in New York City? I mean, I'm going to look into what ACS, which is our big public child welfare agency here, how they handle transgender families. I mean, I just would hope that there's no issue about handling reports like this. But still, I think it's good to explore. And I don't know, maybe I have a student who works for ACS here. I don't know, how much he knows about the policy, but Bernice?
I don't have those laws here, thank heavens.
Right, I doubt it.
So, I don't even know the word for it, as in Texas. So we wouldn't, we don't, hopefully our ACS and other employees do not feel compelled to, there's no vehicle, I don't think, without that law. We just have to be vigilant to make sure. I can't imagine that would happen in New York, but
right,
we have to protect other states too, to the extent that we can.
And I see Karen's hand up, so I think she may have a follow-up or a comment to that.
Oh, hi.
Okay, yeah. I wanted to say that unfortunately, I think it could happen in New York. It probably does happen in New York. I'm more familiar with these issues around, child protection and child abuse, that the recognition that even in places where we have social oversight, that the system is so intrinsically, I'm just going to be blunt, racist and biased, that there's a lot of individual vulnerability to any number of issues, that it's a very complex problem. So, I think that it's not just policy. We don't need just policies. We need a lot of individual training and even group awareness of, at the very least, our unrecognized biases.
Mm-hmm.
Well, also, I'm thinking that in our role as a committee, we perhaps need to make the case for, especially, and it'll be wonderful when we hear from Mama Dragons about their new work, but the association between, trans kids and adolescents and their mental health, that this is a question of autonomy and family decision making about mental health, that it's so critical for them to be who they are, and so as an NGO, that might be part of our responsibility to better educate the community and legislators and others about the connection. It's not just a political issue or a philosophical or religious, but really as mental health professionals, I think all of us agree that it's an issue of mental health. And so
Okay.
our efforts maybe can be directed somehow in that way. That might be something we can work on during the year.
And Holly, you're making an excellent segue to our next presentation from Dr. Jack Turbin. Thank you very much, Eric, for your presentation, and we'll keep the rest of the questions for the end. But it is now my pleasure to introduce our second panelist, who may be known to some of you as he was panelist on our first ever program dedicated to LGBTQIA mental health 2 years ago, and I'm truly honored to have him back. Jack Turbin, MD, MHS, is an assistant professor of child and adolescent psychiatry at the University of California, San Francisco, and affiliate faculty at the Philip R. Lees Institute for Health Policy Studies. Dr. Turbin graduated from Harvard University with a BA in neurobiology and earned his MD and MHS degrees from Yale School of Medicine, where he was an HHMI Medical Research Fellow and graduated with highest honors with an award-winning thesis entitled Evolving Treatment Paradigms for Transgender Youth. He completed his adult psychiatry training at McLean and his child and adolescent psychiatry fellowship at Stanford, where he was also the chief fellow. His research has focuses on the mental health of transgender and gender diverse youth, particularly as these topics relate to public policy, and has been cited in major court cases regarding the civil rights of transgender people in the U.S. And also in state legislative debates around the country and in the United Nations Independent Expert Report on Conversion Therapy. His peer review work has appeared in several journals, including the New England Journal of Medicine, JAMA, and the Journal of American Academy of Child and Adolescent Psychiatry. He is the co-editor of the textbook Pediatric Gender Identity, Gender Affirming Care for Transgender and Gender Diverse Youth, and is regularly consulted by the media to comment on issues regarding mental health and topics related to LGBTQ health. The title of his presentation today is Research Update, Supporting the Mental Health of Transgender and Gender Diverse Youth Across the Lifespan, and I'll read his abstract. This session will discuss the latest research regarding the mental health of transgender and gender diverse youth. It will open with a discussion of the mental health disparities experienced by this population, as well as frameworks for understanding these disparities, including concepts of gender minority stress and physical gender dysphoria. Results from a focus group of adolescents with gender dysphoria will be presented, including top things these young people want physicians to know. The session will then discuss the latest research on how to support transgender and gender diverse youth at various stages of development, and topics will include approaches to supporting pubertal children, including considerations of early social transition, and adolescents, including consideration of prepubertal suppression with gonadotropin releasing hormone agonists, and consideration for gender affirming hormones. Session will also present research regarding the negative impact of gender identity conversion efforts on mental health. So I pass it over to you, Jack. Thank you for being with us today.
Thank you. Also, I'm still reeling, Eric, from how great that presentation was. I almost wish I had done a different presentation now, because there's so much of this legislation passing that it's really been a flood that's hard to follow. And to your point, there's so much misinformation out there. So hopefully I can cover the data that's useful to bring to these policy discussions for one specific topic, or I guess two. So conversion efforts in these bans on gender affirming medical care. But if anyone's interested in the data for some other things, like the data showing that trans-inclusive bathroom policies lead to lower rates of assault, things like that, always feel free to email me, and I'm happy to help. Let's see, can you see that okay?
Mm-hmm.
So just for disclosures, I received textbook royalties from Springer Nature. I'm on the scientific advisory board for Panorama Global's fund that was set up by Melinda Gates to promote adolescent mental health during the COVID-19 pandemic. I've received extra witness payments from the ACLU, Lambda Legal, and some of their partners. A pilot research award from the American Academy of Child and Adolescent Psychiatry and the pharmaceutical partners, including Arbor and Pfizer. A Sorensen Foundation Fellowship, and various freelance payments from news outlets. So as Felix mentioned, we're going to basically walk through various stages of development to talk about how to support the mental health of transgender youth at those different stages and the relevant research that's important to know. But first, just a little bit of terminology and background to make sure we're all on the same page. 4 main terms to know from this gender bear. So first is sex assigned at birth. This refers to what's on someone's birth certificate, usually based on the appearance of external genitalia at birth. This is different from one's gender identity, which is your psychological sense of your gender, whether that's male, female, somewhere in between, or some different gender identity. That is different from romantic or sexual attraction, which refers to the types of people towards whom you're attracted. And we use the reference point for this as gender identity. So if I were a transgender woman who was attracted to other women, I would like to identify as a lesbian, but it's obviously helpful to ask people what terms they're most comfortable with. The last concept is gender expression, and this refers to the way in which you present to the world in a gendered way. So I have short hair. If I were wearing a suit, you might think of that as a masculine gender expression. If someone were wearing a dress, you might think of that as a feminine gender expression. But of course, these things vary substantially culture to culture and also even across time within a given culture. I usually will quiz people about these genderbread cookies, but I'll skip this for now. Unfortunately, there are high rates of psychiatric morbidity among trans and gender diverse youth. Most of this tends to be internalizing psychopathology, which means anxiety or depression. So depending on the study, in the age of the participants, you'll see mood disorders like depression as common as 64%, anxiety disorders as common as around half, and these seem to drive high rates of suicidality as well. There are different predictors of these adverse mental health outcomes, but one really important one is stigma, and in particular bullying. And some studies have said as many as 80% of these kids have experienced bullying based on their gender identity or gender expression. So on this graph, on the y-axis, this is the percentage of participants in a given study who reported a history of a suicide attempt. And on the x-axis is the mean age of the people in the study. This gray line represents the US average, and then this black line represents transgender and gender diverse people. And so you can see really across the lifespan, there's this dramatic disparity in suicidality, in that it really seems to intensify in middle school into young adulthood when experiences of stigma often amplify. The predominant framework for understanding these mental health disparities is the minority stress framework, which many of you may have heard of. This originally was described by Elon Meyer to talk about sexual minority people, so lesbian, gay, and bisexual people. Originally, he was referring specifically to cisgender gay men, but it describes the ways in which these different elements of societal stigma impact mental health. First, it talks about distal stress factors, so things from the outside world, things like being rejected for being trans, being discriminated against, non-affirmation of one's gender identity. I think that's intuitive for most people, but was slightly more novel and less intuitive were these proximal stress factors. And these are things that start to live within your own psyche as a result of those external factors. Things like internalized transphobia. So I take care of a lot of trans youth who are constantly hearing in the media things like, you shouldn't be able to participate on sports teams that align with your gender identity because you're going to be physically dangerous to people. Or they hear you shouldn't be allowed to use the bathroom that matches your gender identity because you, as a trans person, are a sexual predator, or your trans identity is a mental illness. A lot of these kids know none of those things are true on a conscious level. But subconsciously, they may start to internalize some of those ideas and think, what if I am dangerous? What if my identity is a mental illness? And you can see how those things over time would drive anxiety and depression. Another one is negative expectations of victimization in the future, which is very similar to what we see in all trauma-related conditions. So if you, throughout your childhood and adolescence, experienced a lot of discrimination based on being transgender, then let's say you move to San Francisco, to the Castro, where the environment is relatively more accepting. you may still continue to expect that discrimination and have constant anxiety around it, and have a lot of trouble gauging when are situations safe and when are they not, which can be particularly toxic to mental health. The good news is that the model identifies some resilience factors, so ways that you can buffer against the negative impacts of societal stigma. And these are things like community connectedness, so knowing other LGBT people, and also pride in one's community. So for a lot of my trans youth, we'll talk about trans role models and how we see successful examples of trans people in medicine and the arts and law, public policy, et cetera. One thing that I didn't map on here that I have been recently, that to Eric's point, I really should have, is that public policy impacts all of these things, right? You can have public policy that impacts the distal stress factors. You can have public policy that impacts the proximal stress factors. And you can also have public policy that promotes these resilience factors. So when thinking about both federal and state public policy, it's sometimes helpful to map them onto these different domains of minority stress theory. This is a focus group that we did with a group of trans adolescents, asking them the top things they wanted their doctors to know. And I like to include their voices in these presentations. So a few that I'll point out. One is that they talked about names, pronouns, and gender markers being important. And on one level, these are really important just for validating someone's experience of their gender identity. But there's often another level that goes back to some of that trauma we were talking about. So if you use the wrong name or pronouns for a trans youth, that may bring up a lot of past experiences, like parents who rejected them, or maybe even threatened to kick them out of the house for being trans, or a bully who threw them into a locker and misgendered them. So what these kids said is that if you use the wrong name or pronouns, just know that you maybe bring some of those things up. And what can be really helpful is just to apologize and remind them that you're on their team and there to support them, and that you're not going to be like those people in the past. So that's background. Let's talk a little bit about supporting very young trans and gender diverse youth, so prepubertal children. 3 models have been described historically. The first is the living in your own skin model. Most would call this gender identity conversion efforts at this point, which have been labeled unethical and dangerous by all major medical organizations. But I include it for historical context because it wasn't that long ago that it was being practiced. And as recently as 2002, there were peer-reviewed publications describing how to do this from psychiatrists. And what this was implementing different, I hesitate to call them psychotherapeutic, but different psychological interventions to try and push prepubertal children to identify what their sex assigned at birth. The thought being that you could prevent future stigma that they would experience and prevent the need for gender-affirming medical interventions that carry side effects. On the other end of the spectrum is what's practiced, certainly throughout most of the US and increasingly around the world, which is the gender affirmative model for prepubertal youth. This has been politicized, and it's often framed as kind of like pushing a trans identity on a child. It is not that. So what it is just giving a child a space where they can explore their gender freely without the therapist having a goal in mind. So the goal isn't for the kid to become cisgender, the goal isn't for the kid to become transgender, but to allow the kid to explore in an open setting and really fight those stigma factors we were talking about. So how can you work with the school to make sure the kid's not bullied? How can you work with the parents around their anxieties when their kid exhibits these behaviors? And how can you make sure the kid is developing strong relationships with parents, peers, and the therapist, and also developing resilience and self-esteem that's gonna make sure they have strong mental health later in life. There's an intermediate model that's been described in the Netherlands called the watchful waiting model. This one often is misrepresented as well. People will sometimes use this phrase to mean waiting until adulthood to consider any gender-affirming medical interventions. That is not what it means. So it specifically is about prepubertal children. And what it was that the Dutch would say, don't do any therapy to try and push the kid to identify as cisgender. That could be shaming and dangerous. But also don't recommend a social transition, so taking on a new name, pronouns, etc., until puberty. And if we have time at the end, we can talk about the rationale for that. If this sounds complicated, that's okay, because it comes down to really 2 questions. Number 1, is it recommended to do psychological interventions to push kids to be cisgender, these gender identity conversion efforts? And we'll talk about the data showing that that is dangerous, likely. And the other question is about social transition and what happens if these prepubertal children take on a new name, pronouns, etc. So let's look at early social transition first. We don't have a ton of data, but this is the data that we have. So as you go to left and right, towards the right, those are higher levels of anxiety and depression. Red is the clinical range, orange is the preclinical range, green is the normal range, if you will. Then I put 3 cohorts of kids on here. So 2 of the cohorts are from clinics where they tell families to not let prepubertal children socially transition. And then this is a cohort in the US of community recruited kids who were allowed to socially transition. And you can see those who socially transitioned had essentially normative rates of mental health, and those who weren't had mean scores more in the preclinical range. It's an imperfect comparison for many reasons. These kids are in different countries, data were collected in different years. But I think what's important to take home from this is that at the very least, these kids who are allowed to socially transition do very well, and pretty much just as well as their cisgender peers, suggesting that there's nothing inherent in their trans identity that's contributing to bad mental health, but really the way they're treated by those around them. And that the social transition itself is not inherently dangerous, but rather people's reactions to it. I didn't put the paper in here, but we published one in the Journal of Adolescent Health, where we found that adolescents who socially transitioned during adolescence actually had a higher odds of adverse mental health outcomes than those who waited until adulthood. But when we went back and adjusted for K through 12 harassment based on gender identity, that went away, and the kids who socially transitioned actually did better. But just to highlight that when young people are socially transitioning, it's really vital to work with schools and communities to make sure that they're going to be treated well in order for their mental health to be optimized. Another question that comes often, especially in these legislative arenas, is this question of whether or not a social transition intensifies a kid's trans identity, or if it makes them more likely to continue to be trans in the future. There's a study from Christina Olson's group at Princeton, Ray et al. In psychological sciences that looked at whether that was true or not. And essentially they found that the stronger degree of gender incongruence or transness, if you will, predicts that a kid's going to socially transition. So the trans kids are the ones that are likely to transition, but their degree of trans identity or gender incongruence doesn't intensify after the social transition, if that makes sense. So this idea that a social transition makes kids more trans is not supported by the data. So that's social transition. The other question is about these conversion efforts. And for a long time, most conversion therapy, if you will, or conversion effort research was about lesbian, gay, and bisexual people and sexual orientation change efforts. So trying to force lesbian, gay, bisexual people to be heterosexual. And there wasn't as much data about what happens when you try and force trans people to identify as cisgender. So to look at this question, we used the US Transgender Survey. It's a non-probability sample of over 27,000 trans adults. And we looked at only those who had ever spoken to a professional about their gender identity. And then we compared people where that professional tried to force them to be cisgender with people where their therapist didn't. And what we found was that these conversion efforts or attempts to force transgender people to be cisgender were associated with a whole range of adverse mental health outcomes, including lifetime suicide attempts. We also specifically looked at when those conversion efforts were administered during childhood, right? So this question of prepubertal children. And we found that the association with suicide attempts was even more dramatic. So a 4-fold increase in adjusted odds of suicide attempts. Suggesting that contrary to this living your own skin model, which said that for prepubertal children, it may be advisable to do that, it actually looks like it might be the most dangerous to do that for prepubertal children. Which if you just think about basic psychology, it makes a lot of sense that if you're instilling in someone's mind very early that who they are is wrong or shameful or something to be changed, that'll drive anxiety and depression and suicidality later in life. Despite this, conversion therapy is still legal in most of the United States. So if you look at this map, the dark green states are those that have banned conversion efforts. And the rest of the states are states where it's still legal to practice. People often ask how common conversion efforts are for trans people. So we looked at that same sample of 27,000 trans adults and asked them if they had ever been exposed to conversion efforts in their lifetime. and 13.5% of them had been exposed to that at some point in their life. And as you can see, there was some geographic distribution, and where this was more common, the red states had higher rates of exposure, the blue states had lower odds. These bans on conversion therapy that you saw, all those dark green states, are being challenged in the US courts. And it's important to know what's happening at the appellate level. So 2 circuits, the 9th and the 3rd Circuit, ruled that conversion therapy bans were constitutional and upheld them. But more recently, the 11th Circuit considered 2 conversion therapy bans in Florida and ruled that they were unconstitutional and that they were violations of professional free speech. In it, they said that they acknowledged that the American Psychiatric Association has labeled these practices dangerous, but they went on to say that the American Psychiatric Association used to say homosexuality was a mental illness, and now they don't. And therefore, these medical organizations are capricious and can't be trusted, which you can imagine is a dangerous, potentially slippery slope argument that allows you to ignore all evidence and medical consensus. So with this circuit split, it seems possible that this question might go to the Supreme Court in the coming years, and that'll be important to follow. The actual constitutional law is somewhat complicated, but if people are interested, we can talk about it in the question and answer session. Those are the questions about prepubertal youth. I want to talk briefly about gender-affirming medical interventions, the first of which that would be considered is pubertal suppression. Under current guidelines, the most common ones are the Endocrine Society guidelines and the World Professional Association for Transgender Health Standards of Care. No medical interventions are considered for prepubertal children. The first medical intervention that might be considered is pubertal suppression, and that's considered once kids reach these early stages of puberty. Another thing that I'll point out that's often weaponized, if you will, in these political debates is that in child and adolescent psychiatry and psychology, the term child and the term adolescent have very different meanings, even though in everyday speech, people may use them interchangeably. So children in our research realm means prepubertal children. And adolescence means kids who have reached the early stages of puberty. So kids between starting puberty and adulthood. So let's talk about those early stages of puberty. I'm going to skip the in-depth physiology, but suffice to say, these medications essentially pause this axis between the brain and the gonads, so the ovaries or testes, to tell that axis to stop producing estrogen or testosterone so that puberty is put on hold. The interesting thing about these medications is if you stop them, so you either stop the injections or you remove the implant that's releasing the medication, that axis will turn back on and your puberty that you would have gone through without the medication will proceed. So in that sense, we consider them reversible. The first clinic in the world to publish on doing this was the gender clinic in Amsterdam at the UMC. I like to remind people that Amsterdam is very beautiful and their clinic is spectacular if you're ever interested in learning more. And they published this case report in 1998 of a young trans boy who told his parents that he didn't want to live anymore if he had to live as a girl, and wrote a suicide note to the parents. And endocrinology in the community started a puberty blocker. Later, this adolescent came to the gender clinic in Amsterdam and received testosterone, eventually had gender-affirming surgery in adulthood and had a very good outcome. So after this was published in 98, this started being done more and more in their clinic and also at clinics around the world. And the medication can be provided different ways. So there are depot injections that are every 3 months, daily injections that are not typically used, and then these subcutaneous implants that are really similar to the birth control subcutaneous implants that you may have seen. They'll last about a year. They're marketed last year. Clinical research suggests they last more around 2 years. And again, if you want to go through your birth puberty, you can remove the medication. This is the data we have on the impact of mental health from puberty blockers for trans youth. So you can see they're mostly longitudinal cohort studies looking at how mental health changes before and after. And then there have been 2 cross-sectional studies comparing adolescents who received these medications to those who desired them but weren't able to access them. And generally, all these studies have linked pubertal suppression to lower rates of anxiety and depression and suicidality, and better global functioning. So that's puberty blockers. Later in adolescence, an interdisciplinary team, that would be a mental health professional and an endocrinologist usually, might consider gender-affirming hormones, estrogen or testosterone. Older Endocrine Society guidelines recommended not considering these until age 16. But the most recent guidelines note that there may be circumstances in which you would start earlier, as young as around 13 and a half. Interestingly, the latest WPATH standards of care removed the age requirements altogether. My interpretation of that is that most people will still generally follow these older age requirements, but really consider it on a case-by-case basis, depending on the adolescent and their circumstance. You can imagine that you may approach a young person who socially transitioned when they were 6 or 7. Maybe they started a puberty blocker when they were 10. They're now on their second puberty blocker. And I have a patient like this other day. She turned to me and said, "In what world am I gonna be a boy? Why are we waiting longer? Because all of my peers are going through puberty and I'm not." And we also know that while you're on puberty blockers, you fall behind a bit on bone density. So there's potentially a reduction of that risk if you start gender-affirming hormones earlier. I won't go through in detail all the physical effects of gender-affirming hormones, but just know that there are these tables in the Endocrine Society guidelines that go through all the physical changes when they start and when they reach their maximum. And obviously, it's important to talk to people about how many of these changes are irreversible. So for instance, testosterone will thicken and lengthen your vocal cords and deepen your voice, and that's not reversible later. Under current guidelines, minors need to have a comprehensive biopsychosocial evaluation by a mental health professional with specific training to be able to start these medications, which is another important thing to know. Here's the data on gender-affirming hormones, so estrogen and testosterone for adolescents with gender dysphoria. Again, mostly longitudinal cohort studies. Most notably, there was a large one published in the New England Journal that followed 315 adolescents through 2 years of gender-affirming hormones. And those adolescents had improvement in life satisfaction, anxiety, and depression. Also, 2 cross-sectional studies that compared those who accessed gender-affirming hormones to those who desired them but weren't able to access them. And when they accessed these interventions during adolescence, those people had lower odds of depression, suicidality, psychological distress than those who weren't able to access gender-affirming hormones. So that was a whirlwind. And I like to go through it quickly just because there tend to be a lot of questions and I like tailoring the time to what's most useful for people. So I do put up this list of questions that I'll leave up for a few seconds. That if any of those particularly interest you, we can talk about those in the question and answer sessions. And I have some appendix slides that go through some of those questions if people are interested.
All right, awesome. Thank you very much, Jack. Does anybody have a question?
I have a question.
Go ahead, Eric.
Speaker can ask another speaker a question. So thank you, Dr. Turman. So I've been very impressed with your, continued work to do education, not just on the academic side, but also in the popular media, because this is really where these policy arguments are playing out. And, there's been some worrying trends that I'm sure you're following in terms of major publications, really putting having biases on display in terms of how these questions are framed, which really then leads to these articles being used as sort of a policy argument of why we need to do this. And so you have advice for folks who may reach out to journalists or who journalists may reach out to get understanding on or background on these issues or how their organizations are approaching these issues in terms of whether like best practices or guidance that you might offer where people could learn more.
Like the best way to work with journalists, is that the question?
And ways that you found to make sure that the information that journalists report out there is accurate and not like heavily biased.
Yes. So it's a big question. One thing I'll say is it's very useful to be like proactively engaging with the media. So if this data is not out there and it's not in public knowledge, it's very easy for politicians to spread misinformation. And then people go vote because they don't know the truth of the situation, right? And we're seeing that all the time, that people are saying that, young children are having gender affirming surgeries, which is not true, or that puberty blockers make kids sterile for the rest of their lives, which is not true. So one thing that I have found really useful is if you see a state that's considering legislation and you're worried that they're not really talking about the accurate evidence-based information, pitch an op-ed to the biggest newspaper in that state, so you can get out to voters this information. I think people are often think about sending op-eds to national outlets, but sometimes if you want to educate around a specific policy, it's sometimes useful to educate the public there. And it's also useful for them to see when their politicians are lying, because that impacts how they vote in the future. And the more you kind of write those op-eds, and maybe if you also have a social media presence where you're trying to push forward information, you're going to get more of those journalist requests. This is a super complicated area. And my biggest fear is that I'll ever misspeak or say something slightly wrong, because I don't want to be guilty of the same thing these politicians are doing. So when I work with journalists, I usually ask for quote approval. So telling them, I'm happy to speak with you, but I would rather it either be through email so I can make sure everything I tell you is very precise and accurate. Or can we do a phone call where you tell me all the quotes you're going to use and I'll correct anything that's inaccurate. Often journalists will say no. To me, that could be their editorial policy, or it could be a red flag. So I'll not do the interview in that space. The other thing that's nice is you start building a big platform on social media with other journalists. If you get misrepresented in your interview, or if you see that coverage is inaccurate or biased, like has sadly been the case in some publications that I think you're referencing, I'll make sure that I'm pushing out the information in that article that's not true to other journalists, so those journalists can cover the inaccurate reporting from the other paper. I hope that's helpful. It's kind of a tough question.
Thank you.
Thanks. Any other questions from the audience? Right, well, we will move on to our next set of presenters, but Jag, hang around because I'm pretty sure there'll be questions later. And our next set of presenters are Proud Mama Dragons, an organization that returns to our program to give us an update on their amazing work. Mama Dragons provides support groups, parenting classes, and a community of 9,500 mothers learning to better support, affirm, and celebrate their LGBTQIA+ children, building more healthy and happy families. Mama Dragons programs are focused on supporting and educating mothers during the essential first year of their child coming out, and those from non-affirming families, religious, and cultures. We are joined by Celeste Carolyn, LMFTA, Executive Director for Mama Dragons, and Nika Allgood, PhD, board member and former president of Mama Dragons. Celeste Carolyn is an accomplished business leader and marriage and family therapist who has made it her mission to support the LGBTQ+ community. Raised at the Latter-day Saints in Montana, she came out as queer in her 20s at BYU, Idaho, a conservative college, which led her to work with LGBTQ+ youth and nonprofits. In addition to working with Mama Dragons leadership, she works as a marriage and family therapist, specializing in helping LGBTQ+ teens and neurodiverse individuals and couples. She has a bachelor's degree in leadership and psychology from BYU, Idaho, completed master's coursework at Harvard Extension Business Management, and holds a master's degree in marriage and family therapy from MCU. Her expertise in business and mental health has helped her navigate the complex landscape of LGBTQ+ advocacy and support. Dr. Nika Allgood is a passionate advocate for LGBTQ+ rights and equality, particularly within the Latter-day Saints community. She is a mother of a transgender son who came out in May of 2011 and does LGBTQ+ activism in Utah. Beyond her activism, Nika is a successful business owner alongside her husband, owning and operating a small engineering consulting company. And her education has also played a significant role in her life and work. She holds a PhD in molecular biology, which has given her a deep understanding of the science behind gender identity and sexuality. Nika uses her knowledge to educate others and combat harmful myths and misconceptions surrounding these issues. Her dedication and expertise make her an invaluable asset to both Mama Dragons and the broader LGBTQ plus community. And I apologize, I kept reading Nika because this is the bio that I got from her. I should have probably said Dr. Oldwood all along. So apologies for that. I pass it over to Celeste and Anika.
Thanks everybody for inviting us to be here. I represent Mama Dragons as the executive director. And what we're going to do today is talk to you just a teeny bit about our organization since we appeared here last year, and then talk more about the impact about anti-trans legislation on our families. So as you read, the primary thing that Mama Dragons provides is peer-led support groups. We support right now close to 10,000 moms throughout the US. We also offer parenting classes about raising LGBTQ youth, where we use a lot of videos and storytelling to impact, especially moms that come from conservative environments, to help them understand that there's other parents just like them that have learned to become affirming. If we go through a little bit about our intersectionality of our moms, right now over 60% of our mothers joining Mama Dragons for support programs have kids under the transgender umbrella, which has been kind of a flip over the last 5 years. It used to be primarily moms with kids who were gay, lesbian, bi, and it's flipped more to being under the trans umbrella. Interesting enough, our roots are in Mormonism. And so the organization started out of Utah, and 35% of our mothers come from or identify as LDS or Mormon. And then 31% come from some Christian background religion. This is essential because we provide a unique intersection of conservative religion and ideologies, where I think that a lot of people have a hard time impacting those groups. The other thing is we provide services primarily in the US and Canada. We also have support groups throughout the world, including New Zealand, and other areas. Our primary amount of moms live in Utah, California, Washington, Texas, Idaho, and Florida. And these states are really interesting because if we look at some of the bigger issues we're having, a lot of these states are impacted. The primary amount of what Mama Dragons does is focus on accepting parenting. I know that people here know the research. Why we focus on accepting parenting, it seems to have a bigger impact on our parents and our mothers, and they tend to understand that their behaviors directly impact their LGBTQ youth. And that's where we start with our parent education. And it directly impacts essentially how our youth are able to function, especially as they're being primarily raised in communities that have non-affirming social structures. Overall, Mama Dragons has grown significantly, which is positive and sad. We exist because these parents need support, and we continually can grow because of this lack of support in communities and families. What we see is that the community offered in Mama Dragons is something that generally they don't have within their own ecosystem. So whether that be their family of origin or their community at large or within their religious community. Our support groups essentially focus on primary areas of just a primary support group, which all mothers can join. We also have a very specific mothers of transgender and non-binary children. That group is growing rapidly, and those topics focus just on those issues. We also really focus on the intersection of religion and raising your LGBTQ child, and we try to meet people where they're at religiously. We have specific LDS focused religious groups where some people are active within those religions and are trying to affirm their child. And we have folks that have left those religions and are trying to cope with those changes and faith changes and find new support groups. We also have regional support groups throughout the US and globally, Spanish speaking groups. And then we recently launched a Mamas of Color support group. Sorry about that. This last year too, we also launched a new podcast called In the Den with Mama Dragons. Based upon what we know about storytelling and the change that happens within family dynamics, the storytelling basis of the podcast has been really effective for us. And it covers everything from political things that are happening in the environment to trans youth talking about their stories. And it really focuses on that parenting journey, where most podcasts will focus on other aspects. What we're really trying to do is impact the parents and community leaders that are the decision makers, often for these LGBTQ youth. We still continue offering suicide prevention courses. We offer them weekly, and we try to get our parents trained in QPR because it's just such a high risk for our parents. We have certified trainers, and we're working on programming in this next year to offer advanced suicide prevention courses because our parents often are working not just with acute suicide prevention, but chronic suicidal ideation and self-harm. 2 years ago, we launched Parachute, which has been really successful. We've had over 7,000 parents take education courses. The concept of this e-learning course is really to get parents anywhere in the world to sit behind a computer in the privacy of their own home and learn the basics of having an LGBTQ child from the parenting perspective and from storytelling. If you have clients or people that need resources like this, Parachute is pretty extraordinary because it comes from that perspective. This quote came out this week for the Human Rights Campaign. I imagine many are aware of, but the Human Rights Campaign this week officially declared a state of emergency for LGBTQ people. And this kind of starts that transition over to Nika to talk more about how this is impacting our mothers.
Thank you, Celeste. So the Human Rights Campaign state of emergency was declared primarily because of the flood of anti-LGBTQ bills being proposed at the state level and the number of those bills that are being made into law. These anti-LGBTQ bills fall into several categories. We've already talked about some of them, particularly the bans on transgender and gender diverse youth accessing transition-related medical care. But there have also been bans on transgender youth participating in sports as their affirmed gender, and bans on transgender youth using the bathroom at school, bans on schools asking students their pronouns or on honoring students' requests to use their preferred name and pronouns. Furthermore, there are some states that have passed book bans that try to remove books that contain LGBTQ characters from school libraries. Often those bills empower a single protesting parent to censor the reading material for a whole school. There have also been a number of drag bans that either proposed or passed. These bans tend to label any performance that includes a person dressing in clothing stereotypical of the opposite sex as adult content and therefore inappropriate for minors. This map shows some of the states that have passed one or more anti-LGBTQ bills. I want to point out that this graphic is not up to date. I live in Utah, and Utah has in fact passed both a ban on transition-related medical care and a sports ban. It's just this is the most updated map we could find online. The impact of these laws on transgender and gender diverse youth are particularly brutal, particularly those bans that deny children access to appropriate health care. Often legislators present these bills as being relatively harmless because all they're doing is asking children to wait until they're 18 before they access care. But the reality is that that wait is not neutral. Youth who are denied access to hormone blockers might watch in horror as their bodies develop irreversibly: height, big hands and shoulders, a deep voice, or wide hips. Young people who deal with gender dysphoria that would be largely treatable with appropriate hormone therapy will be left to struggle for years with the depression and anxiety that accompany gender dysphoria. And youth who are denied access to appropriate restrooms are at greater risk for developing urinary tract infections. It's also important to understand the broader impact of these laws on LGBTQ people's mental health. Even if an LGBTQ person is not directly impacted by one of these laws, the messages the laws send to LGBTQ people are that they are other, and that they are people who the state sees as people who do not deserve the same civil rights and equal treatment as their peers. I live in Utah, and several of my adult transgender friends have talked about the impact the passage of Utah's anti-trans laws have had on their mental health and their sense of safety in their own community. What's more, these legislative attacks create a climate where domestic terror groups or lone wolf assailants feel empowered to attack the LGBTQ community. In the last few years, there have been multiple mass shootings that targeted LGBTQ people, and the number of threats against LGBTQ people in their traditional places of safety have risen. This year, several of my mom friends reported that their queer children did not feel safe attending Pride festivities. Next slide. In response to these laws, there are parents, particularly parents of transgender and gender diverse children, who are choosing to relocate their families to states whose laws are more affirming. These moves come at a huge cost to parents and their children. The financial impact is often significant. Plus, every family member is uprooted from their friends and their support network. But being able to relocate one's family is a huge privilege that not everyone has. For many parents, they cannot find jobs in more affirming states, or the cost of housing in those states might be prohibitive. For other families, child custody agreements prevent a move. So for many families, their only choice will be to remain where they are, doing the best they can to shelter their children from the storm of hostile legislation that swirls around them. Next slide. So what can we do to support LGBTQ people, particularly LGBTQ young people? This is where a systems view of care is so useful. Just like farmers use a greenhouse to protect seedlings from cold and wind, waiting to transplant the plants into open fields when the plant is larger and the weather more clement, we can build a greenhouse of shelter around LGBTQ young people. The strong ribs of the greenhouse are supportive parents, teachers, coaches, therapists, healthcare workers, religious leaders, friends, and so on. In this model, even a single rib of the greenhouse provides important protection, but the greenhouse protects best when the ribs are linked and working together to support the structure. Next slide. The people attending today probably already want to be a part of that greenhouse of support. But it's one thing to want to be supportive and another thing to know how to be usefully supportive. Mama Dragons focuses a lot on that how to support LGBTQ youth. One way to support is to help a person who might feel alone to see themselves as not alone, but as part of a community. I am the mother of a transgender son. And when my son Grayson socially transitioned 12 years ago, he had good support from his parents and his extended family, from his school, and even mostly from our conservative church. But he was the only transgender person he knew. I didn't want him to feel so alone. Fortunately, I was able to find a support group for transgender people an hour's drive away from our home, and I took him there several times, just so he wouldn't be the only transgender person he knew. A few years later, my son and I had the opportunity to make a YouTube video with Equality Utah, where Grayson shared his story of being a transgender member of the Church of Jesus Christ of Latter-day Saints. I was truly amazed at how many other transgender members of our church reached out to Grayson. It was common for them to say, "I thought I was the only one," or "I thought I was alone." But Grayson was able to give them that bridge, that connection, to see that they were not alone, that they were a part of the community. I loved when Dr. Turbin talked about seeing role models in their community, because it helped me see how my Grayson had been able to be a role model for his community. Another way to help a person feel usefully supported is to help them feel defended, not just attacked. In some instances, this is community members literally showing up with rainbow umbrellas or angel wings to shield LGBTQ youth from the view of protesters. We can also help people feel defended when we publicly speak out as individuals or organizations against laws that prevent professionals from following the standards of care recognized by our various professions. We can also teach parents to be more resilient in the face of these attacks on their children, and parents model resilience for their children. One of the strongest ways that children learn to be more resilient is seeing their parents put principles of resilience in action. Finally, it's important that we educate ourselves on the best practices of our profession for supporting LGBTQ people, and then bringing those best practices into discussions with our peers. Next slide. Mama Dragons, its primary focus is supporting parents so they can be a strong support for their children. But we also share our resources with the broader community. The public can access our QPR suicide prevention trainings and our Parachute e-learning platform from our website. And our podcast is available for free on most podcast platforms. Our Facebook support groups remain exclusively for mothers. But a huge barrier for mothers getting support from our groups is simply them learning that we exist. So we invite you to share information about Mama Dragons with parents that you interact with, so that they can go from feeling alone to feeling part of a community. Thank you for your attention today and for your caring.
Thank you very much, Celeste and Nika, for your presentation. Are there any questions from the audience? And I do have a question I asked Nika earlier. Mama Dragons, mothers, is it only, are you providing support only to mothers?
And we serve mothers and people who are in a mothering role.
Celeste?
Just to add to that, we don't use gender identifiers within Mama Dragons. We understand that the word mama is a binary verb, but we also understand that our target market is folks that identify with that language, because we're really focusing on moms that come from a conservative environment, that we're really bringing in folks that need the most support and help. At some point, that language may change, but today it's still the binary mother that we're focused on. Right now, I believe 95% of our moms are cisgender mothers, and about 5% are not.
Thank you for that. Any questions? Holly?
I want to thank you so much for being here, all of our speakers, and also for ending on a positive note, because you know, this material is just so distressing. I'm a nurse, and just to think about all the suffering that is institutionally derived and so unnecessary and cruel and heartless is overwhelming. So I'm always feeling positive about the work that you all are doing, but especially Mama Dragons providing a service. I do have a question that's not so optimistic of our psychiatrist. And that is, I've just spent 3.5 days with Bessel van der Kolk and others. And a significant amount of time was degrading the DSM. And I'm just wondering what your thoughts are about gender dysphoria and those kinds of diagnoses.
I'll let Jack go first specifically on that diagnostic part, and then I have a little bit to say about the DSM itself.
Thank you.
Yeah, so there's been a long tension in the DSM. You may have known that when they removed homosexuality, they added transsexualism. But that diagnosis evolved over time into gender identity disorder. Obviously, a lot of people are uncomfortable with that term because it implied that their gender identity itself or transness was disordered. So that was changed to gender dysphoria in the latest DSM, which was meant to reduce some of the stigma. And basically the argument that people have continuously is, we know that mental health diagnoses are often used to promote stigma and disenfranchise people. On the other side of the spectrum, people say, we need these diagnoses to get insurance coverage for a lot of the types of care that these patients need. And so often there are arguments back and forth. Well, what the ICD did was they moved from gender dysphoria to gender incongruence, and they moved it out of the mental health section. Strangely, they moved it into the sexual health section, which to me is bizarre and maybe like differently offensive. But just to acknowledge that, this isn't like a mental health condition per se, being trans, and that you may still be a candidate for gender-affirming medical interventions. The way that's interpreted in medical practice in the US is a little bit different because most guidelines still use gender dysphoria rather than the ICD method. My personal opinion is I think it would be great if we could just not stigmatize mental health conditions. I wish it weren't a problem for it to be in the DSM, but I understand that the reality is that it is. And in these political debates, despite the fact that the DSM is very clear that transgender identity is not a mental illness, that nuance is always lost. And people say, look, it's in the DSM, it's a mental illness, so we should do conversion therapy or cure you. Again, the APA has a very clear policy statement that you should not do that, but that nuance is lost. So I think the conversation is just going to continue to be this debate between, do we need a diagnosis for access, and is having a mental health diagnosis causing more harm than good?
Yeah.
Well, yeah.
Go ahead. So jumping on that, and then the other kind of practicality piece in that is the research piece, having like a diagnostic clarity or at least consistency. So I want to go back a little bit to that, that kind of political determinant of health model, that circle, so we can apply that itself to the APA. And so the organization, that I'm the vice president of now, AGLP, so that had a strong historical role in removing homosexuality from the DSM. And so the way that the DSM get put together is by a steering committee, and the way that people get on these steering committees. So this is all kind of, in the same way, it's this somewhat political process. And so as the voting membership of the APA changes and the way that these things change, so does the leadership of the APA and the people who write the DSM and the researchers that are, put in the kind of the leading positions to write different chapters and things like this. And so the DSM itself is also somewhat of a political document. And then there are these tensions that Dr. Turbin described of the practicalities of research and funding. If we don't do that, then people aren't going to be able to get the care that they need, and we won't be able to have research consistency. But that continuing to understand that it being in the DSM itself is a bit problematic for multiple reasons, which he talked about.
Thank you.
Any other questions? We're coming to the end. Okay, timed it very well. All right. If there are no other questions, I'll move on to my closing remarks. Thank you, Ms. Carolyn, Dr. Allgood, Dr. Raphael, and Dr. Turbin for your very comprehensive presentations, which are really a reminder of how the social determinants of health affect our LGBTQIA+ community, the importance of supporting research addressing the mental health of individuals throughout the gender continuum, including the persistently marginalized and victimized transgender population. Supporting research in intersectionality, as our struggles as LGBTQIA+ individuals are compounded by the convergence between our orientation, gender, but also other social identities. The importance of also strongly advocating against laws and policies that give carte blanche to discriminatory practices, supporting our children, our youth, and being mindful of the language that we use, as we all know that words matter, have meaning, and they can not only hurt, but they can also affirm and support. Thank you all for attending and participating in our third annual NGO CMH program, fully dedicated to LGBTQIA+ mental health during World Pride Month. I welcome you to join our NGO Committee on Mental Health and express your interest in joining any of our working groups, including the working group on LGBTQIA+ mental health. And I'll just put the link right on the chat, which I should have queued up, but it is NGO mental health. Org. I'll add it in a second. And I would also like to give a plug to my mental health show, Sin Salud Mental No Hay Salud, which is actually going to air at 4 p.m. And I have to run there, it's already pre-recorded. But it's no Sin Salud Mental No Hay Salud, of course, means no health without mental health. And we will air our episode on LGBTQIA+ mental health. The show is in Spanish, but it is closed captioned in English on our YouTube channel. So I thank you all very much again for your attendance today. And I turn over to Holly for the final goodbye.
Thank you very much, Felix, and all of our presenters. I think this has been so informative, and as dismal as some of the data is, it's refreshing to have a source of honest, trustworthy, and hopeful information that we can take back to our NGOs and our various communities to try to use to better serve humanity. So we look forward to seeing you probably in September at our next meeting, but we will be communicating with everybody throughout the summer. We do encourage you to go to the website and join our committee, and also think about providing some direction for your NGO to apply for affiliation with the UN. And if you need help with that, many of us will be able to help you, because we need to form coalitions within the United Nations system itself, especially with some of the legislation that's going around in other countries that are really detrimental, like Uganda and other countries that are detrimental to health and mental health. So we look forward to hearing from you. Thank you so much, our presenters, and especially to Dr. Felix Torres for organizing this wonderful program. Thank you.
Thank you, everyone. See you all soon. Bye.